Okay, shall we start? A very good evening and a warm welcome to everyone who presented here. I'm Pandami Nastri from Government Tuberculosis Medical College and Hospital, member of IMA-MSN, and it is a privilege for me to serve as a moderator for today's session on behalf of the Indian Medical Association Medical Students Network, IMA-MSN, Tamil Nadu State Branch. I extend a very warm welcome to all the respected dignitaries, our esteemed speaker, and all the participants who have joined us today for this informative seminar on seeing the TB beyond the chest, a clinical tool of extrapulmonary tuberculosis. At the beginning, I would like to respectfully acknowledge the constant guidance and encouragement provided by the patrons of IMA, Tamil Nadu State Branch, Dr. B. Sridhar Sir, State President, IMA TNSB, Dr. P. Sengituvan Sir, IMA Past President, IMA TNSB, Dr. A. K. Ravikumar Sir, President Elect 2026, IMA TNSB, Dr. N. R. Tyagarajan Sir, State Elect, IMA TNSB, Dr. N. Thiraviyan Mohan Sir, State General Secretary, IMA TNSB, Dr. D. Salaman Jaya Sir, State Finance Secretary, IMA TNSB. I would also like to convey my sincere regards to our state leadership team, Dr. R. Annamali Sir, Chairman, IMA-MSN TNSB, Dr. S. Jamuna Rani Ma'am, Co-Chairman, IMA-MSN TNSB, Dr. V. S. Hariharan Sir, Chairman, IMA JDN TNSB, Dr. Kanan Rajendran Sir, Convener, IMA-MSN Subcommittee, and a special appreciation to the state members who continuously support the activities of the Medical Students Network. Arnagiri Sir, Convener, IMA-MSN TNSB, Ajay Karthik Sir, General Secretary, IMA-MSN TNSB, Bala Hariharan Sir, Co-Convener, IMA-MSN TNSB, and Hariharan Sir, Hariram Sir, Co-Convener, IMA-MSN TNSB. On the World TB Day, we look beyond the lines to recognize the hidden faces and tuberculosis. Extrapulmonary TB can affect multiple organs with subtle, often missed symptoms, making early diagnosis crucial. With advancing diagnostic and targeted treatments, we are better equipped to detect and manage these forms, bringing us closer to complete TB control and the TB free world by 2030. It is indeed a pleasure to have with us Ms. Raihana Tazmin from Chengalpattu Medical College as a speaker of today's seminar. As a final year MBBS student from Chengalpattu Medical College, Raihana Tazmin stands out for her strong academic drive and passion for tuberculosis care. She has been actively involved in research papers and poster presentations, reflecting her curiosity and commitment to evidence-based learning. Her enthusiasm, perspective, and dedication to growth make her a promising future healthcare professional. Today's session is sure to be engaging and insightful under her presentation. Without further delay, Miss Raihana, let us begin today's session. And now, it might to kindly deliver her talk and share her valuable insights with us. Over to you, Raihana Tazmin.
Thank you, Pandamina. It was a sweet introduction. So let's start. I'll share my screen. Is it visible? I'm audible, right? Yeah, okay. So good evening, everyone. Myself, Raihana Jasmine, final year student from Chengalpattu Medical College. So as we all know, the theme of today is extrapulmonary tuberculosis. So as the topic itself speaks for itself, we'll be taking a clinical tour of extrapulmonary tuberculosis. So I'd like to start the session with an interesting case I saw in my surgical postings. So it was a case of 40-year-old male who was a manual worker with a painless swelling in the palm for in the flexor aspect of the wrist for 3 months, with a difficulty in finger movements for 2 months, and occasional discharge was present. We were asked by our chief to do a cross fluctuation test, which was also positive. So only these were the major findings, and he also had a low-grade fever with a loss of appetite. So looking at this, what all the differential diagnoses you can think of? Anyone? Okay, so we thought it could be some due to trauma, some hematoma formation, right? That's what we thought. Because the Yeah, correct. Actually, it's a ganglion. He also told us he had a history of trauma recently, so we were thinking in that way mostly. So, on detailed history taking, we came to know that he was a known case of TB patient and he was on irregular medication for a couple weeks. So, it is actually a case of Palmer compound ganglion. So, what is it basically? Due to chronic granulomatous inflammation, you have the inflammation of the tendon sheath and the joint capsule in your flexor aspect of the wrist. So this is a case of Palmer compound ganglion. It's a very rare manifestation of extrapulmonary tuberculosis. We have another term called as Palmer compound ganglion, where the entire thing goes for necrosis. So this patient did not have any bluish or blackish discoloration. So this is mostly a case of Palmer compound ganglion. So this made me think that TB is not confined to one particular disease. You can be posted in many, either surgery, medicine, or ortho. Regardless of that, you should keep this one point, that is TB, in your back of your mind always, because it is not confined to one system. It is a multi-system disease. So that is what makes this session very important if you're in a CRRE period or even in your final year. So coming to the basic definition, we all know that the primary foci will be in the lungs. By hematogenous or lymphatic spread, the foci will be disseminated to any part of the body. So this is like a prevalence of all the systems that are involved. So primarily the lymphatic system is involved, followed by pleural TB, bone or joint, that is osteomyelitis or Pott's disease, followed by genitourinary TB, meningeal, peritoneal, and followed by others. So this is the basic pathophysiology. Till this, we all know, I guess, initial infection, innate immune response, and all. We have this granuloma formation. After that, you have three major fate. It can either be digested by the alveolar macrophages, in which case there will be spontaneous healing and the patient will recover. If that does not happen, it can either go for latent primary tuberculosis. So the patient will present with recurrent pulmonary tuberculosis. And the third case is that extrapulmonary tuberculosis. So that is the lymphatic or hematogenous spread, due to which the patient will present with multi-system involvement, that is extrapulmonary tuberculosis. So as we know, that TB affects many parts of the body, starting from the head till to the toe. We from the head, what do we have? We have TB meningitis, followed by CSOM, TB CSOM, pharyngitis, or you can also have TB of the contralateral lung, or you can have a TB pericarditis. And if you come down, what do you have? In GIT, it does not spare any organ. You can have peritoneal TB, you can have a hepatic TB, you can have a intestinal TB. And in we all know this psoas abscess, right? It is a kind of cold abscess, so it also does not spare the bone and the muscle. And in case of urinary TB, we have adrenal TB also, and it can also affect the urinary bladder, ureter, anything. And in case of genital TB, you have endometrial TB, salpingitis, or vulval TB, cervical TB, etc. We'll be talking about all this in the further slides. So yeah, like I said, it is a clinical tour. So I'll be taking you on a TB hunt. So this is the itinerary of the tour. I will be your fellow tour guide. So what is our mission? Just think of TB as a little annoying guy who does not stay in one place. So he does not stay in one city. He likes to travel a lot. So our mission is to hunt this guy down. We are going to track him down, starting from the CNS till to the genitourinary tract, and we'll be talking about the lymph nodes and joints also. So the mission of today is to track down this tuberculosis and to combat all the some symptoms and investigations. So our first destination is the lymph nodes. So in lymph nodes, what do we have? We all know this term, scrofula. What do we call it? TB lymphadenitis. So this picture is very familiar, I guess. So this is a case of TB lymphadenitis affecting the cervical lymph nodes. So how does the patient present? So usually the patient will present with a single group of nodes at a single site. So it will be mated. That is, it will be close to one another. When you are palpating, the group of lymph nodes, they will be sticking to one another. So it is called as mated type of lymph nodes. So mostly it will affect the cervical, submandibular, and supraclavicular lymph nodes. You can also have the lymphadenitis in the abdominal or mediastinal TB. So on palpating, how will it will be? It will be painless, firm, and fixed to the skin. And if this is in case of a cervical TB. So if lymph nodes are in all of our body, right? So if the lymph nodes in the, what do I say, in the hepatic part, the periportal lymph nodes or any other kind of lymph nodes, if that is involved, the patient will present with jaundice, or he can also present with renovascular hypertension if there is compression over the renal artery. And one important thing is mesenteric lymphadenopathy, in which the patient will present with intestinal obstruction. So you're looking at a patient, they have a firm lymph node which is fixed to the structures, which is not mobile, and you have a mild erythema or an ulceration over it. So what will you think? The first differential diagnosis is malignancy. So it looks like malignancy. So you should rule out that first. So other differential diagnosis could be lymphoma, non-tuberculous mycobacterial infection, or other bacterial lymphadenitis. So these are the differential diagnoses. So looking at the investigation, so before that, we'll look at the 5 stages. So TB lymphadenitis, it has 5 stages. The first stage, the lymph node will be enlarged, firm, and mobile. Whereas in the second stage, it will be rubbery. It won't be firm. It will be rubbery, and it will be fixed. So these are the first 2 stages. After that, what will happen? It will go for a cold abscess. So these are the 3 stages. After which, there will be a sinus tract formation. But before that sinus tract formation, you will have a collar stud abscess. What is a collar stud? So the sinus won't be completely going to the external environment. You will have an abscess inside and protruding kind of thing in the skin. So that is called as collar stud abscess. So we can see in the 4th image, that is the collar stud abscess. So these are the 5 stages. So first it will be firm, mobile, then it will be fixed to the surface, and it will be rubbery in consistency. Then it will go for an abscess formation, then collar stud abscess formation, then sinus tract formation. So it is Jones-Campbell staging of TB lymphadenitis. So investigation. So we all know the basic investigation, UST, CT. So we can also take an FNAC and decide it for zeal analysis staining or culture. So these are the 3, the top 2 are UST images. You can see it's an hypoechoic area. So in case of a lymph node, why is it hypoechoic? Because it's gone for necrosis, and you have a peripheral enhancement that is due to the exudation. So this is the USG and this is the CT. In CT, you can see 2 lymph nodes with an hypoechoic area. So this is near the portal vein and this is near the pancreatic. So it's one of the enlargement of peripancreatic lymph nodes, and this is periportal lymph node. So with that, we are departing from our lymph node. So our next stop is, okay, before that, this is a case. Can anyone say with the diagnosis of this case? It's a 90-year-old male with 3 weeks of fever, headache for 10 days, vomiting for 3 days. He's drowsy on examination with presence of neck stiffness, and CSF examination has lymphocyte predominance, high protein, low glucose, and on standing, you have cobweb clot. This itself is self-explanatory. Can anyone try? I hope you guys are with me. Can anyone try what this case is? The patient has neck stiffness and he's drowsy.
TB meningitis?
Yes, very good. It is a case of TB meningitis. So our next stop is at the TB and the CNS. So in the TB and the CNS, we will be mainly talking about TB meningitis and brain tuberculosis. Okay, so far, what did we say? In case of extrapulmonary TB, you have a dissemination in the hematogenous or a lymphatic spread, right? But in case of TB meningitis, you have inflammation of the meninges. So basically, how does it happen? You have something called as the epidermal layer. So beneath the layer, you have formation of tubercles. So the ruptures of subependymal tubercle is the main pathophysiology for TB meningitis. So it will go into the subarachnoid space and the patient will present with all these symptoms. So how does the patient present? The patient present just like any other meningitis, but the key difference is it will be subacute in onset, whereas in case of a pyogenic, that is a bacterial meningitis, it will be acute in onset. So other symptoms are fever, stiffness, vomiting, altered consciousness, or the patient can also have a cerebral nerve palsy. In case of advanced cases, the patient will have paralysis, stupor, coma, etc. And the main thing is usually late stage TB meningitis, it presents as a hydrocephalus and hyponatremia. So like I said, what are the differential diagnoses? It looks like a fungal or a viral meningitis. So what did I say? In case of pyogenic meningitis, the onset will be acute, whereas in case of TB meningitis, the onset will be subacute. And other differential diagnoses are neurosyphilis, neurobrucellosis, neoplastic meningitis. So we have already covered the symptoms and signs. Now just look at the staging and severity of this. So we have three stages: early, intermediate, and advanced. No need to complicate actually. In the stage 1, there will be non-specific symptoms. That is, the patient will have lethargy, malaise, fatigue, fever, all that. In intermediate this thing, the patient will have mild altered consciousness, whereas in advanced case, the patient will go for a stupor, coma, or severe neurological deficits. So that is the key difference you have to talk about. So stage 1, stage 2, stage 3, early, intermediate, late, early non-specific symptoms, intermediate altered consciousness, and in advanced severe neurological deficits and stupor or coma will be there. So these are the staging of severity in TB meningitis. So looking at the investigation. So basically, you take a CT, MRI, and CSF analysis. Like I always already said in the case that we saw, the CSF analysis will do so a lymphocyte predominance, increased protein, and cobweb clot formation will be seen. That is, on prolonged standing, cobweb clot will be formed. So this is a picture of a CT in case of TB meningitis. So you can see this white thing in the base of the skull. These are nothing but the basal enhancement. That is, what enhancement is nothing but a lot of due to a lot of exudation. That part of the brain alone will take a lot of contrast. That's why you have an enhancement in this basal region. So this is called as basal enhancement. And what are these black areas? These are nothing but cerebral infarcts. So in CT, you have basal enhancement and cerebral infarcts. And what is this? This is MRI picture. In MRI picture, you have something called as optochiasmatic arachidonitis, which is nothing but you have the arachidon. So what is basically TB meningitis? The inflammation of meningeal layer. So arachidonide. So in case if the arachidonide matter is inflamed, you have this kind of finding. Basically, this arachidonide matter lines the optic chiasma as well as the optic nerve. That's why in this you have multiple ring enhancing lesions. So this ring enhancing lesions are nothing but scarring plus exudates. These exudates are the white part that you are seeing, and the scarring are the black one which is in the middle. So this is a sign of optochiasmatic arachidonitis. This is an MRI picture. So you have to diagnose TB. So basically, if there is hydrocephalus, basal enhancement, which is nothing but this white thing, and cerebral infarcts. If you have all these three findings, 95 to 100%, you can be sure that it is a case of TB meningitis. So this is the three main thing. If the patient is presenting you with a hydrocephalus, you are taking a CT, you are seeing a basal enhancement and infarction, you can say that I'm 95% sure it's TB meningitis. So that is TB meningitis. The other condition in the brain is brain tuberculosis. So it is basically the patient will be asymptomatic. So what is basically tuberculosis? It is basically a space occupying lesion. You can see multiple nodules in the brain. This is like multiple nodules, or it can also present like a single nodule that is in this image. So multiple enhancing lesions are seen, and surrounding edema is also seen. So this is a case of brain tuberculosis. This is very similar to another this infection that you have seen in our microbiology. That is neurocysticercosis. In that also you'll have a similar picture. So you have to be cautious about that. So neurocysticercosis, cryptococoma, toxoplasmosis, brain abscess, these are the differential diagnoses. So we are departing from the CNS. So next stop in our clinical tour is the heart. So in heart, the TB will mainly affect the pericardium. So we are only going to talk about TB pericarditis. Okay, so tuberculosis pericarditis. It is no rocket science. You have only two main things, that is effusive pericarditis and constrictive pericarditis. We will be seeing one by one, side by side. So what is effusion? What is constriction? In effusion, you have some fluid in the pericardium. In constriction, that fluid that is in the chronic stage, the fluid has gone and fibrosis has happened. So the heart is not able to expand. So this is the basic pathology. So in effusive pericarditis, it is a subacute onset. Whereas obviously for fibrosis and all to happen, it should be a chronic thing. So constrictive is a chronic thing, whereas effusive is a subacute thing. And the patient will also have constitutional symptoms. Like the patient will present with constitutional symptoms in case of effusive because it's subacute, whereas it will be absent in case of constrictive pericarditis. And in both of these things, the patient will always have four main symptoms, that is raised JVP, hepatomegaly, ascites, edema. So it is a heart pathology. Why are we having hepatomegaly and ascites? Can anyone try? I said the pathology is in pericardium. The heart is unable to expand. So why is the patient presenting with hepatomegaly and ascites? Come on, people. Okay. I hope you guys are with me.
Overload.
Yeah.
Any
Come again?
volume overload?
Yeah, you're almost there. So basically, what is near the near the liver? So since the heart is unable to expand, you have a lot of congestion in the IVC. So there will be, the liver can go for a chronic venous congestion, due to which you will have a hepatomegaly. And why is ascites coming? Because of portal hypertension. Obviously, in some liver pathology, you're going to have a portal hypertension, due to which you will have a ascites. So the patient is presenting with all this. Like I already said, the pericardial space has fluid in case of effusive, and it is stiff in case of constrictive pericarditis. So coming to the main complication. So main complication in effusive pericarditis is cardiac tamponade, whereas in case of constrictive, it's right heart failure. We just talk about it. So we have something called as the Beck's triad in cardiac tamponade. Can anyone tell me what are the three components in Beck's triad? What is cardiac tamponade actually? You have a lot of fluid in the pericardium, so the heart is unable to expand. So what will the patient have? You have something called as the Beck's triad. So it's nothing but the patient will have raised JVP, that is one, and hypotension will be there, and muffled heart sounds will be there. So this is the Beck's triad. So coming to the management. So in case of effusive pericarditis, like I just said, if there is cardiac tamponade, you will do an emergency pericardiocentesis to relieve the pressure. And if there is not to avoid a tamponade, you will do inferior pericardiotomy. That is, you're creating an opening so that in future the patient won't develop any cardiac tamponade. This is in case of effusive pericarditis. In case of constrictive pericarditis, you will do a pericardiectomy. That is, you remove the entire pericardium because it is a symptomatic thing. The patient already has went for fibrosis, calcification, etc. So you will do a pericardiectomy. Okay, so what is the X-ray finding in both? So like I said, the pericardium fully has fluid, that is serous fluid. So the heart will be enlarged. So you'll have a flask-shaped heart in case of effusive pericarditis. Whereas in case of constrictive, you can see a ring of calcification, right? So there is no enlargement per se. You will have a ring of calcification because it is gone for fibrosis. So calcification will be seen. So this is the key differentiating points. So obviously, you'll also do echo in both to rule out cardiac tamponade, etc. So that is about TB in the heart. So we are departing from the from the heart. Our next stop is the GAT. We are almost halfway through our hunting down this notorious guy who can't stay in one city. So we have to keep following him, hunting him down. So yeah, we'll go for the GAT. Can anyone say in GAT how does it? Okay, it's given here itself. Can anyone say in GAT how does TB present as? Come on, guys.
Intestinal tuberculosis.
Yeah, intestinal TB. What else? You have arrived the GAT now. Come on. What all are there in the GAT? Intestinal TB, very good. That is the most common TB the patient will have. What else do we have? Peritoneal TB, hepatic TB, or even if the lymph nodes in the abdomen are affected, you will have a mesenteric lymphadenopathy. You can just say whatever comes to your mind because it does not spare any organ. Okay, so this is just like a pathogenesis. There is nothing much to see here. Like I said, you have it goes to the node, that is from the hematogenous spread, you will have a low-grade bacteremia from which there will be a nodal TB and Peyer's patches. So Peyer's patches are in the ileum of the GAT, right? So you'll have a ileocecal TB, that is most common, or you can just have an intestinal TB. What are the types in intestinal TB? Ulceration, hypertrophic, or ulcerohypertrophic. If the if the node ruptures, you will have a peritoneal TB. So in the peritoneal TB, you have a wet type and dry type. The wet type is ascites and the dry type is plastic. And you also have a miliary TB. That is, it can affect the omentum, peritoneum, liver, spleen, etc. So mainly we'll be talking about intestinal TB, peritoneal TB, and hepatic TB. So ileocecal TB. So in the GIT, particularly in the intestine, the ileocecal junction is the most common site for TB. Can anyone say why? You have like 4 points, I think. Ileocecal TB is one of the long case for final years also in surgery.
Very narrow
Just
area.
given. Yes.
It's very narrow.
Almost. Yeah.
It also has the lymphoid tissue, Peyer's patches, and
yes, very good, very good. It has Peyer's patches. Then 2 points. 2 more points. Yeah, okay. Very good, actually. Sorry, I can't see your name. Okay, so you have Peyer's patches, so a lot of lymphoid aggregate, that is 1 point. And you have increased transit time. That is another point. And alkaline medium will be there in the IC junction. And one more thing is that IC wall. If you have a competent IC wall, there will be increased, I mean, the whatever that foci is there, it will be there for a longer duration, which will increase the risk of the ileocecal TB. So yeah, as I said before, it can be ulcerative or hypertrophic. So how does the patient present? Like any other abdominal condition only. It can be abdominal pain, fever, weight loss, anorexia, nausea, vomiting, altered bowel habits, etc. And the patient will have palpable RIF mass and signs of acute intestinal obstruction. So since RIF mass is a long case, what are the other differential diagnoses for RIF mass? It can be CA-cecum. So in CA-cecum also, patient will have a palpable RIF mass. Then why Crohn's disease? In Crohn's disease also, all the investigatory findings, which we'll talk about later, the radiological picture of ICTB will be exactly same to the Crohn's disease. So that's why these come under differential diagnosis. So I have one more question. So we talked about ileocecal TB as RIF mass, right? We have one more condition in TB itself, which will present as a RIF mass, which is not ileocecal TB. Can anyone try? We just talked about it in our first stop, in our first destination. So it will be RIF mass. The patient will be a TB patient. He will have a RIF mass, but it won't be an ileocecal TB. What could it be?
lymphoma.
Yes, very good. Mesenteric lymphadenopathy. So in mesenteric lymphadenopathy also, you will have a palpable RIF mass. Very good. So coming to the investigation, this is the barium swallow study in which you have two main signs. Here you can see the cecum is pulled up. It is known as gooseneck deformity, and the ileum is very narrow. It is known as string sign. Both the string sign and the gooseneck deformity is seen in Crohn's disease also. So this is the two basic signs in ICTV, and you can also take a colonoscopy for biopsy. So what is the surgical management for ileocecal TB? Right hemicolectomy. So what is right hemicolectomy? You take 10 centimeter of the ileum, the entire ascending colon, along with the hepatic flexure, and 1/3 of the transverse colon. So this is called as right hemicolectomy. We have something called as extended right hemicolectomy also, in which the same procedure, but instead of taking 1/3 of the transverse colon, you take 2/3 of the transverse colon along with the entire middle colic artery. So we don't do that for ileocecal TB. For ileocecal TB, we do right hemicolectomy. So a patient comes with you with signs of obstruction. It's not like you just go and do a right hemicolectomy. You first relieve the obstruction by doing a iliotransverse bypass, which is nothing but anastomosing the ileum with the transverse colon. You do that first, then you take a biopsy. If it comes positive for TB, you finish the ATT, and then you proceed with the right hemicolectomy. This is the ileocecal TB. So the next condition is the peritoneal TB. We already talked about it. We have two types of peritoneal TB, that is the ascitic type, wet type, and dry plastic type, in which you will have a lot of adhesions. So if it is a wet type, how will the patient present? There will be slow accumulation of ascitic fluid over weeks or months, and it can also be with abdominal pain and fever. So you have slow accumulation of ascites, right? What will you think? The patient is in some DCLD, decompensated liver disease. Like that you will think. So that is one of the major differential diagnosis. What else can it be? The bacterial or fungal peritonitis, or it also can be malignancy. So what do you investigate for peritoneal TB? There is no any specific investigation. You do exploratory paracentesis. You drain the fluid and you analyze. The fluid will be straw colored, lymphocyte predominant again, with low serum ascites, albumin level, and elevated ADA levels. And we also have something called as the abdominal cocoon syndrome. This is seen in wet TB or dry TB. Obviously, it will be seen in dry TB because you'll have a lot of adhesions. So there will be small bowel obstructions, due to which you have a lot of cocoon type of dilations will be seen due to small bowel obstruction. This is known as abdominal cocoon syndrome, seen in dry type. So the last this thing in GIT is hepatic TB. It is not very common. Just for the finishing sake, I have put. So how does the patient present? Obviously, the patient will have abdominal pain, jaundice, and also constitutional symptoms. Mainly in the investigation, what will you see? You will see a lot of hepatic nodules, calcification, and peripheral enhancement. It can either be a solitary nodule or multiple nodules can be seen. Like in the CT, you can see multiple nodules. In UST, you can see a single hypoechoic area is seen. Hepatic nodules are seen. So we're departing from the GIT. Okay. We have traveled all the way from the brain. Now we are reaching the TB and genitourinary system. So this guy, he doesn't want to, like, he not just the current generation. He say I will also disturb the future generation. So also the genital system and urinary system is involved in case of TB. So we'll talk about genitourinary system. In case of genitourinary system, mainly for our academics, female genital TB is mainly important. So we'll be renal and urinary TB. Just for completion's sake, we will just see what and all it will affect. In case of adrenal gland, if it affects, you will have adrenal insufficiency. So you'll have decreased cortisol and all that other symptoms will be there. In case of like if there is a renal TB, that is if the kidney is involved, you will have dilated pelvis and dilated calyces will be there. So it is known as hydronephrosis, or the ureters will have strictures that due to which the patient will have a flank or loin pain, and the bladder will be contracted, and the patient will have symptoms like hematuria, dysuria, what else? Like uh, all other symptoms, just like any other UTI infection, only the patient will be presenting. And one main difference is that the patient will have a sterile pyuria, that should be noted. So coming to the okay. So this is the main thing in the genitourinary system. So female genital TB. We look at the prevalence, like how much the TB is affecting each of the part in the female genital TB. Sorry, female genital system. So the major, most common is the fallopian tube. In fallopian tube, what will we get? We will get tubal TB, that is salpingitis. So in salpingitis, all these are laparoscopic pics. I mean, these two are laparoscopic pics. Sorry. Okay, so the main gold standard for female genital TB is laparoscopy only. So that's why I have put all these laparoscopic pics. So we'll see one by one. Major, it is tubal TB, followed by uterus, that is endometrial TB, followed by ovarian TB, followed by cervical TB, followed by vulval and vaginal TB. So in case of tubal TB, what will you have? You will have thick and rigid fallopian tube will be there. And inside the lumen, what will be there? Cheesy material will be there. Due to which you will have a frozen pelvis appearance will be there, and edema and congestion will be present in tubal TB. In salpingitis, we have a lot of types. It can be endosalpingitis or exosalpingitis, or it can also be interstitial salpingitis. So in case of endometrial TB, what will you have? You have multiple adhesions. You have a name for this syndrome. Does anyone know? In endometrium, you have multiple adhesions in case of TB. It is called as Asherman syndrome. So this is a laparoscopic pic of all the adhesions you can see. There will be irregular cavity also. So in case of cervical TB, this is a picture of cervical TB. You can see there is irregular, abnormal discharge is present. thick, cheesy discharge is present, that is seen in cervical TB. And in vulval and vaginal TB, chronic ulcers, nodules, abscess, dyspareunia, all these can be seen. So, what will be the major clinical features in case of any part of the female genital system is involved? You will have all these things. So, there will be menstrual disturbances. First, in the initial phase, the patient will have menorrhagia, and in the later stages, the patient will have oligomenorrhea. And the patient can have chronic pelvic pain, infertility, abnormal discharge. Like basically, abnormal discharge is seen in cervical TB. Abnormal bleeding can also be there. Infertility is mainly seen in both endometrial TB as well as tubal TB. And chronic pelvic pain is seen in any TB. So all these picture, what does it mimic? It mainly mimics like any other pelvic inflammatory disease. So proper history taking and examination is important. So investigation, like I said before, the gold standard is laparoscopy, followed by ultrasound and hysterosalpingography. So these are the images. We have three main signs. We have a lot of signs. These are the, I just put the main ones here. So this is something called as pipe stem tube. So this is the fallopian tube. It looks like a straight pipe, right? So usually how is the fallopian tube? It is tortuous. So the tortuosity is lost. This is a case of interstitial salpingitis, due to which the stem is, the tube is like a pipe. So this is a pipe stem tube. This is a golf club tube. This is seen in when the fimbriae is affected. So when the fimbriae is affected, there is an appearance like golf club tube. And this is what you call it as a beaded tube. This is seen in endosalpingitis. So that is about female genital TB. Male genital TB, you don't have much clinching points. So basically, entire tract can be affected. Chronic archepididymis is the most common. The patient will present with a scrotal nodule or epididymal thickening can be there. The patient can have a hydrocele or also infertility can be there. And you can only rely on biopsy for male genital TB. So that's about the genitourinary system. So we are almost at the end of our expedition, or whatever you like to call it. So our final destination is the bone and the joints. Though it's a final destination, it's the most common. After pleural TB, it is the most common site to get affected in any individual, from children to adults. So we'll look at the bones and joints. So TB in bones and joints. So what is the main pathophysiology here? There can be a dissemination, but mainly what happens is the dormant tubercles will be reactivated, and that is one possibility. Or in case of POT, that is the spinal TB, that is POTS disease, you will be having spread from the paravertebral lymph nodes. So these are the two pathophysiology in case of TB bone and joints. So basically, this POTS disease and TB osteomyelitis are most common, followed by TB arthritis. So we'll look at POTS disease first. We all know, I think we have all seen at least one POTS case in our lives. So what vertebrae does it usually affect? Usually the lower thoracic and upper lumbar is affected. So how does it spread? It spreads from the intervertebral joint to the vertebral body, and then it goes to the adjacent disc space. So due to this, the patient will have a spinal compression, that is medullary compression is possible. So the patient can have a paraplegia or tetraplegia. And in advanced cases, a cold abscess can be formed, and draining sinus can be seen. This is something you call as Alderman's gait, in which the patient will be having their hands back and their chest and abdomen will be in the front. He does this to prevent jolting of the spine. So this is known as Alderman's gait. This is a picture of pot spine in children. So coming to TB osteomyelitis, since POTS disease, it has a specific preference. Like I said, in the vertebra, but TB osteomyelitis, it can present anywhere. For example, if it presents in the chest, you will have a cold abscess over the chest. Or if it goes to the fingers and toes, dactylitis can result. So you can see it is affecting even in the throat area, in the thigh region. You can see these are pics of osteomyelitis. So coming to TB in joints, that is TB arthritis, you have two main types in TB arthritis. So one is the normal TB arthritis that we all know. So what does it affect? Any native or prosthetic joint is affected in TB arthritis, whereas we have something called as Ponson's disease. In Ponson's disease, there is immune mediated inflammation. So it's an immune mediated thing, but it's due to TB only, but it's an immune mediated thing. So in TB arthritis, you will have a single location, whereas in Ponson's disease, there will be poly or oligoarthritis. Especially knee and hip are involved, whereas here both large and small joints are involved. So what will the patient have? In TB arthritis, it is more aggressive in nature, whereas Ponson's disease, the patient will have a better prognosis. So in case of TB arthritis, the patient will have a subacute painful swelling with loss of joint function. Cold joint and draining sinuses will be present. In Ponson's disease, the patient will have a good prognosis. There won't be any joint deformity or anything. There will just be a pain, polyarthritis or oligoarthritis. We need to see POTS disease alone in general. I mean, like in detail. So investigation, what will you do? You can do X-ray spine, CT, MRI, CT guided FNAB. For AFB, we can send that. So this is the X-ray image. In X-ray image, you can see that there is a demineralization of the vertebrae, and there is obliteration of the disc spaces is also seen in X-ray. Also in CT, you can see there are destruction of the vertebral bodies, and also the disc spaces are obliterated. And in MRI, you usually see if the spinal cord compression is seen, or even adjacent joint, soft tissue is involved. For that, you take an MRI. In this MRI, you can see that it is invading the spinal cord. It is compressing over the spinal cord. This is the spinal cord. So yeah. So we have some bonus stops to look at. That is cutaneous TB and miliary TB. Cutaneous TB, it's very, very, very uncommon. You just need to know the names. So the classification, it is like exogenous, endogenous. In exogenous, it can be a chancre or verrucosa cutis. In endogenous, it can be contiguous, hematogenous, or lymphatic. We have all heard about scrofulloderma, cutis orificialis. And in hematogenous, you can have acute miliary tuberculosis, lupus vulgaris. And in lymphatic also, you'll have lupus vulgaris. Lupus vulgaris is nothing but the patient will have apple jelly nodules in the face. Miliary TB, that is one more very, very aggressive form of TB. It will have both lymphatic and hematogenous spread of tuberculosis. So this is an X-ray image in miliary TB. So there will be bilateral uniformly distributed miliary nodules, 1 to 3 millimeter in diameter. So how will the patient will be the patient will be having multi-organ failure. So along with the night sweats, along with the fever, the patient will also have a multi-organ failure in miliary TB. So with this, we come to the end of our expedition, but still the hunt doesn't end here. Every diagnosis brings us closer. So the more we explore TB, the more we get into eliminating TB as a whole. So TB is still a global challenge. Any patient presenting with multiple system involvement, we should highly suspect that it is a TB. So yeah, thank you. Any doubts or any queries? Yeah, I see a lot of people have answered in the chat box. I'm sorry I couldn't see it because I was screen sharing. Yeah, muffled heart sound, very good. Gentle Internet TV. Thank you guys. Good response.
So thank you so much, Raihana Tasmin. It was really a wonderful session, and I have also learned a lot of disease. We have one question from chat box from Yashwant Elmulai. What's the other name for Ponson's disease? This is a question for audience. Anyone like to answer this question?
Other name, Ponson's disease. It's a tuberculous rheumatism, like reactive arthritis due to tuberculosis.
Really, thank you. Is there any other questions from the audience side? Or shall we wind up the session? Okay, now we will be winding up this session with a vote of thanks. It is my privilege to propose the vote of thanks for today's enlightening session on seeing TB beyond the chest, a clinical tool of extrapulmonary tuberculosis. I extend our heartfelt gratitude to our respected state patrons for their constant guidance and support, and to the MSN team for their vision and efforts in making this seminar possible. A special note of thanks to our speaker Raihana, final year MBBS Changalpur Medical College, for delivering such an insightful and inspiring session. Your clarity, enthusiasm, and dedication truly made a difference. I would also like to specially acknowledge our organizing team and members of their seamless coordination and commitment, Dashini GS, Parthasarathi, Sri Hari, and finally Akash. Finally, I thank all the participants for their active involvement and interest. With that, we conclude today's session. Thank you all.
Hey, just a minute.
Yeah?
Yeah. I have sent a feedback form. Participants kindly spend some time in filling it. Thank you. Yeah, I'll share it there also.
Thank you, Akash.